Hi, everyone. Thank you for joining us today. We will be discussing new endovascular options for the treatment of peripheral artery disease, a case review and panel discussion with some of my colleagues here. Along with me, I have Sam Seifu from Baylor Scott and White Heart Hospital in Plano, and then Peter Monteleone from Austin in Texas. Without further ado, let's get started with our first case. This is an 80-year-old woman with hypertension, preserved ejection fraction, COPD on 4 liters of oxygen, chronic low-dose prednisone. The patient actually reported seeing a wound on her left first digit 2 weeks prior to presentation. Upon presentation, there was noted bone exposure on the first metatarsal head. She underwent pretty emergent digital amputation and partial ray resection. These are her medications, as you can see. So by the time that we saw her, she actually already had her digit amputation. Here you can see along the line of the incision, there's necrosis, suggestive of potentially a perfusion defect contributing to her presentation. On her ABI, TBI, you can see that her initial ABI was 0.68 and her toe brachial index was 0.61. We took her to the cath lab, and here in her beginning images, her iliac arteries were free of disease. In the first panel here, what you'll see is that the superficial femoral artery had diffuse disease in the proximal to mid segment. There's a mid segment complete total occlusion that then reconstitutes in the distal SFA via collaterals. In the second panel, you'll see that we are crossing in an antegrade fashion with a stiff angle glide wire and a navicross for support. We were able to traverse essentially intraluminally into the distal cap. We were able to then confirm that we were true lumen with a selective below the knee injection. In the third panel, what you see is below the knee, there's diffuse disease in the proximal anterior tibial artery, highlighted here. In the TP trunk, there is diffuse disease. The posterior tibial artery itself is occluded approximately prox to mid transition and is diffusely diseased in the proximal segment. The peroneal artery is fairly robust after the TP trunk disease, and the peroneal itself actually provides nice collaterals into the distal PT, which then feeds the plantar arteries. The dorsalis pedis itself appears to be patent with brisk flow into the toes. So after we had crossed, we placed an embolic protection device. Then we pursued a directional atherectomy with HawkOne LX device. And in the third panel, what you can see is the angiogram after initial run with directional atherectomy. At this point, actually, the wire was dropped and we had to ended up pulling the filter at this point. We were able to luckily traverse back into our initial popliteal segment freely with a 1/8 wire, placed a 5.0 by 200 millimeter balloon for predilation, and then performed drug-coated balloon angioplasty of the proximal mid segment of the SFA using the IN.PACT 018 6 by 150 balloon, and then 6 by 60 millimeter drug-coated balloon. And this was the completion angiogram of the SFA with no major dissections and no further need for stenting. So then we turned our attention to below the knee. The AT and the TP trunk was subsequently crossed without any issues. Balloon angioplasty was performed using a 3.0 millimeter compliant balloon into the AT and a 3.5 millimeter compliant balloon into the TP trunk, respectively. And this was the below the knee imaging post-procedure. Here you can see still a little bit of disease in the AT itself, but good runoff distally without any embolism present. And this was the extracted atherectomy from the device itself. Post-procedurally, her ABI, TBI improved from 0.68 and 0.61 respectively to 1.09 and 0.96. And you can see the dramatic difference in the tracings of the PVR as well. I'll pause here for a discussion on the first case. So Sam, given this case, and can you tell us a little bit about your practice patterns on drug drug-coated balloons and the role of directional atherectomy. How do you use directional atherectomy before any ballooning?
Yeah, I mean, this is actually an excellent case. It highlights a couple of things. One, the importance of education regarding peripheral arterial disease. I mean, this lady had all the risk factors, had an ulcer, had a toe that got amputated before even getting an arterial ABI and you get to your hand. Second, when we see a long lesion like this, there's the old-fashioned way people just balloon, and after the balloon they do a DCB. But we've been more and more aggressive doing directional atherectomy, or the right type of atherectomy depends on the patient case. But for this case, I think directional atherectomy was the right answer. And the highlight also the important use of a filter in those cases, because you will, with a long lesion like this, you will have a dysembolization. In your case, if you do not have a filter, then you'll be chasing below the knee, for hours. So I think it's very important to highlight when you get a directional atherectomy and then you follow it with a balloon and then a DCB, you have a lower risk of dissection. In your case, there was no significant calcification, but even as we learned from reality trial, that even if there's a heavy calcification, long lesion, we still, directional atherectomy has been very useful. I would have done exactly the same thing you've done. I think the only thing that I would have done different, I think you commented about it, is I would not take my filter out till I finish all the DCB, all the ballooning. And the 018 comparing to 035, I think when we use filter almost in every case when we do a directional atherectomy, and trying to put an 035 DCB in a long lesion on 018 or 014 wire, it's kind of challenging. 018 has been much easier to advance. So we use directional atherectomy commonly in a case like this. Above the knee. Below the knee, you can still, if you thought that you needed to do a directional atherectomy, you just need to open a different Hawk 1S, because I think you use an LX in this one. But I think the result looks beautiful.
Peter, along the lines of a directional atherectomy, what's your algorithm for how you treat chronic total occlusions? When do you say, hey, I'm too subintimal for directional atherectomy? Is there any role of intravascular imaging to help you decide that? Do you know which direction to cut if you are subintimal?
Great questions. Wonderful case. Kind of perfect example of kind of complex CTO treatment. In relation to CTOs, like everything in my practice, my goal is to really get to DCB. Scaffolds work sometimes pretty darn well. New generation scaffolds are a little bit better, but we know when they don't do great. Long lesions, calcified lesions, poor runoff. So we're trying to get there, and CTOs are right in the middle of that. So for me in particular, I try to make a decision about right off the bat whether or not I'm going to try to use device-based antegrade crossing, or whether I'm going to use wire-based like you used in that case crossing. A lot of that is dictated for me by what the cap morphology looks like proximally for an antegrade attempt. I use a lot of Viances. We actually have a paper coming out on kind of utilization of Viance to kind of stay close to true lumen. If I think a cap is going to be a really tough cap to cross, I'll use that Viance microcatheter, that braided microcatheter meant to be torqued into plaque to cross. And I try to stay as close to lumen as possible, like we all do. If I can't get across easily antegrade, I try to avoid those big loops of a wire in front of a microcatheter. I'm happy to come up from the foot and then do kind of rendezvous reentry. I'll use IVUS a lot in that situation to make sure that the area where I'm reentering is an area where I'm true lumen. And I can honestly say at this point, I've completely eliminated reentry devices from my practice when I'm crossing. Now, if there's any concerns, you can use IVUS and make sure you're staying near true lumen. As long as you're near true lumen, you can use directional atherectomy in those cases. The only times where it's an issue is if you're far out and in, and you usually get a sense of that just from the path your wire took as it was getting across the lesion. Now, if you're crossing a lesion, and this might not even be in a total occlusion, say you're crossing a somewhat eccentric lesion where the channel through that lesion is running very medial to the plaque, well, then your first couple cuts are going to be cutting lateral, cutting anterolateral, cutting medial. Same thing happens if you get a sense that as you're crossing, your wire, your device is going very lateral, let's say to the calcium, your first couple cuts are going to be cutting towards the vessel. And that's the beauty of directional. You can really kind of optimize the direction of your plaque removal. And it's a big win for those devices. You know, we sometimes think like it's an aggressive device. In reality, it's a conservative application because it gives you the chance to do very targeted, artistic, focused cuts.
Fantastic. I think we will move on to our second case at this point, and then we will resume our discussion specifically about the 018 DCBs. So our second case is an 85-year-old woman with coronary artery disease, had a prior PCI in 2003, hypertension, dyslipidemia, recurrent breast cancer, stage 1 non-small cell lung cancer, had a left lower lobe lobectomy, COPD on 2 liters of oxygen, and unfortunately, she continued to smoke actually. She has peripheral artery disease, had a prior left peroneal angioplasty and proximal SFA DCB about 6 months prior to her current presentation. She presented with wet gangrene of the left lower extremity 4th digit. And because of the urgent presentation, she did actually undergo essentially emergent amputation with our podiatrist. When we took her to the cath lab, we noted a new stenosis in the distal SFA into popliteal artery, as well as a re-occluded peroneal artery. There were some new collaterals that had developed filling the proximal posterior tibial artery. Unfortunately, during our revascularization attempt, despite multiple doses of sedation medicine, she was unable to stay still to the point where we gave her so much that I was a little bit worried about her respiratory status. So we aborted at that time. And then she developed acute limb symptoms overnight. So we arranged for a redo intervention with general anesthesia. And this was her angiogram when we got in the second day after her acute limb development. Here you can see there's a couple of dissections essentially from our initial attempt, and there's actually a thrombotic occlusion now of the TP trunk as well as straddling a little bit into the AT. It's a little bit difficult to appreciate the thrombus here, but everything else is completely occluded. There's essentially no flow into the foot at all. Luckily, we were able to cross into the posterior tibial artery actually in a true lumen fashion antegrade. Our wire kind of sailed through the PT into the plantar, and then we did a quick injection as we got into the plantar to confirm that we were truly inside a arterial structure. And here you can see some venous filling as well after we inject into essentially a very small artery. We did some ballooning, and this was after the initial ballooning. So there's flow, there's still that dissection kind of proximally. So now there's some flow into the PT, but the outflow into the digits, still not great. So we certainly need the outflow, otherwise everything's going to reocclude back up. And here you can see the AT is still out. The peroneal is actually coming back slightly as well. So I left the initial wire kind of towards the toe, took a essentially, I think this was a Suzuki, so essentially a twin pass. And I secured a second wire crossing into the pedal arch and up into the distal AT here in the second panel. The wire felt very free. We didn't actually track a secondary microcatheter in to confirm because I was pretty confident we were in the true lumen. We performed balloon angioplasty all across the pedal arch into the distal AT and dorsalis pedis, and ultimately placed the cutting balloon as well into the lateral plantar artery. And here you can see, I'm going to show you the foot images in a little bit, but we were able to secure better flow into the foot. However, we're still dealing with something on the inflow. So there's still that clot, which you can see in the proximal osteo TP trunk. And then there is a small dissection that traverses from there into the PT. So I wanted to really secure our inflow into the PT. We ended up placing a drug-eluting stent into the TP trunk, kind of straddling into the ostium of the PT itself. And then we post-dilated to a 4.0 proximally into the TP trunk. We finished out, we were antegrade for this case, for this second attempt. We finished out with a predilation of the popliteal artery where that dissection was, pre-dilated with the 5.0 compliant balloon, placed the IN.PACT 0186.0 by 60 millimeter balloon. And this was her angiogram after. You can see the area of the dissection looks much better. And then into the foot, there's a patent pedal arch filling into the dorsalis pedis as well. So her ABI, TBI, when she first started, before the acute limb occurred, her ABI was actually 0.64 with essentially no digital flow. Afterwards, her ABI did improve to 0.86. Her digits still pretty flatlined. I'm actually, this happened only a couple of weeks ago. I'm waiting for her to demarcate so we can essentially give her a TMA. The digit flow still isn't great, but we are still able to obtain a DP as well as a PT pulse, suggesting that the pedal arch is patent still. So I'll pause here for a quick discussion on this case. Any thoughts on how the availability of an 018 DCB changes your algorithm? I actually picked this specific case to present because the beauty was that I could treat the popliteal segment without even converting to a 6 French device. So it gives you more versatility. Any thoughts, Sam, on the availability of the 018 DCBs and the crossing profile? How does it change? How does it change what your algorithm is in terms of treatment for these patients?
I mean, this is an excellent case. It's a nightmare. That's the thing that you don't want to hear in the middle of the night, that case you've done end up being an acute leg, because you gotta know what happened. You know, either you have a dissection, then a clot. As you mentioned you had an antegrade stick for the second attempt, and usually the biggest concern of an antegrade stick is, you know, hematoma from the axis side, and so we'd like to minimize the size of sheath we put in, and 5 French and getting available DCB in a 5 French is very helpful where we can't put it in the, and if you want to use a 6.0 or 7.0, you start talking about a 6 French or 7 French on the IN.PACT 035. Where here you're having your 014 wire or even an 018 wire and with a 5 French. So you're pretty comfortable putting it in without having any difficulties. You know, this case is very, very challenging. You know, it's a question about would you need to do a thrombectomy beforehand if you think that's a clot that's is driving what's happening? Did you have a disembolization in the arch? That's why you had a hard time getting that arch open, because, you know, whatever that clot in the TP trunk or the popliteal shower downstream, stenting versus non-stenting, you know, there's a lot of debate about that, you know, below the knee, and as you mentioned, you most probably you put a Synergy 48 stent, the coronary stent, which we've had a good success with it. We limit our stenting there. You can also use the TAC stent if you want to, if you have it available, which I think it can go. For a small one, I think you can go through a 5 French, if I'm not mistaken. I think the case result looks great. The only thing I was wondering, have you guys thought about, you know, try to go through the AT at this point, or getting the perineal open? I know you guys must probably spend a few hours working on this one in the middle of the night. But is there any thought to bring back the patient back and kind of try to reopen more vessels below the knee?
So that's a great question. My initial goal with kind of this rescue was just to get anything into her foot. And I was pretty happy with the pedal arch staying open. I actually repeated that. I showed 2 pictures of the pedal arch. They were actually before and after I stented the TP trunk. So I was pretty happy that it stayed open even after we had stented the TP trunk. So I was reassured that it was likely enough to give her perfusion into her foot. As you know, the key really to healing a TMA at this point is the presence of a pedal arch. So I think as long as she maintains it, I think it'll be sufficient to heal.
I think you asked Peter about using of IVUS. So my partner blamed me that I use IVUS too much, even though the data for IVUS is below the knee. There's some data that's coming up, you know, that is kind of encouraging. I think this is one of the cases that I would have used IVUS in the location where you have a thrombus versus dissection. It may help you identify what you're dealing with before you start treating, and you know if you need to put a stent or not. And the sizing, and maybe you were undersized the first time around. That's why the dissection did not heal. But I think this case would be useful to use an IVUS to make sure you're intralumen, where you're re-entering back to the true lumen, and how long your stent needs to be.
So those are great comments. I agree. Intravascular imaging is going to continue to shape our landscape of therapy in peripheral artery disease. Peter, I wanted to pick your brain a little bit about using radial to peripheral. As you know, the IN.PACT 018 balloons will be coming out with the 200-centimeter shaft options. Does that change how your practice might be in terms of what you can offer for R2P? As we know, currently there's some balloons that go up to 150, but certainly that's not enough for most patients, especially when you're dealing with a distal lesion.
Yeah, it's a game changer. It's kind of what we've been waiting for, something that's small enough in profile and long enough in shaft length to let us kind of particularly treat simple things simply. You know, dealing with patients with claudication or even critical limb ischemia, the ability to get them in and get them out. So many of them have other comorbidities, like we've seen in both of your patients, where lying down flat for 6 hours after is a pain, blood loss is a pain. You know, I can't wait to be able to advance some of the clinical benefits we've seen with radial access and coronaries truly down into the periphery. I mean, we've had the tech, we've kind of jerry-rigged some devices, short of putting, you know, self-expanding kind of bare metal nitinol stents into the mid-SFA. We haven't had anything else to do. And as we've been doing that calculus in our head, you know, radial access was not worth it to provide a limited at best intervention to the area we were targeting. But now in a world where we can extend our preferred options, you know, our drug-coated balloon therapies, especially with, you know, the type of data we've seen from IN.PACT that extends out to a 5-year mark, the ability to extend those quality outcomes and just be gifted the opportunity to do it from the wrist, it's going to change practice. I mean, I already will, you know, try to work to get everyone out kind of same day for outpatient cases whenever possible. A lot of my cases in the hospital will go straight from their revascularization to the OR, you know, if they're having debridements or partial salvage amputations. And gosh, you always have to walk OR staff through the fact that you can't move the other leg, right? We just close that access site, try to keep them flat. The ability to enhance safety and enhance kind of patient quality by doing those cases from the wrist is a huge opportunity.
So I do want to highlight that you know, a lot of our data that is known around IN.PACT is obviously on the 035 platform. However, the drug, the technology, the coding is all exactly the same on the 018. And I want to take this opportunity to share with the audience some of the sizes that are available on the 018 DCBs from Medtronic IN.PACT. So you still have your 40, your 60, your 80, your 120, and 150. Those are available in 40, 50, and 60 balloon diameters. We also have the availability of 100-millimeter balloon lengths too. And all 3 of these diameters actually fit through 5 French catheters. If you go up to a 7.0 size DCB, that does still require 6 French catheter. Similar to the 035 IN.PACT, the 50 and the 60 actually have 3 folds, 3 pleats where the drug is actually folded into the balloon itself to again minimize the amount of drug loss as we traverse into our lesion. The 40 balloon is folded into 3 pleats due to the smaller balloon size. So you do get a lot of drug retention based on the way that IN.PACT is made, very similar to the 035 system and the way that it's folded. More data will be coming in terms of looking at the 018 efficacy as we use more and more of these balloons, and especially as we apply it in the radial to peripheral algorithm and how it impacts how we treat these types of patients and providing earlier time to ambulation, even in the cath lab or angiography suite holding room. So that should impact patient quality of care as well as satisfaction. I have one final question since we're talking about DCBs. And it's been really a hot topic in the last couple of years. There's been a lot of data since 2019 to really kind of discuss whether or not DCBs should be utilized. Should this remain our frontline treatment algorithm for our patients? Do you still have any concerns, Sam and Peter, about the safety of DCBs? Is this really a discussion of 2019? Should we stop talking about it completely?
I'm happy to start there. So, we learned a lot, I think, as a society, as a network of docs from that whole challenge. I think at this point, Paclitaxel for me is not something I kind of carry any concerns for. At the end of the day, the 5-year data in that meta-analysis was driven by pretty limited data when you dive into it. It was one device that isn't on market. It was partial data from IN.PACT, and it was the Silver data, which had its own kind of complications. We now live in a world where the Medicare, that 50,000+ patient data demonstrated safety. The VQI data demonstrated safety. Voyager PAD prospective demonstrated safety. So I think that's all kind of washed out. And I think what we learned mainly from it is just the fact that we have to be more responsible as we're studying kind of new devices going forward. But for me, there was a window where everyone was quite anxious about this for good reason. I think internationally, we kind of due diligence needed to be done. So I work in an Ascension hospital, Ascension Healthcare. When this first happened, there was a huge drop off in what Paclitaxel devices were being used. And it makes you worry for those patients, right? Because outside of Paclitaxel therapies, drug-coated balloon and stent-based therapies, we're using the stuff that we were using 30 years ago. And I'm so glad that the preponderance of safety data, the hard work that was done, including by Medtronic, who I think chased down every patient who was part of those trials to complete that old data, made a huge difference and let us move forward feeling safe.
So yeah, when we had the FDA alarm, going off when that data came out, automatically, I think if you talk to a physician, nobody had concern really from all the societies that I talked to, part of, and our colleagues who work, both from a vascular surgery, IR, or cardiology. But I think it's more administration-wise. People were just worried about the legality behind it. And for us, we continue to use it. But for 2 years, we had to consent the patient. We had a formal consent, and we had to talk to the patient, explain to them. Now, I'll tell you, out of all the patient we had, none of the patient cared. They just said, if you guys trusted, we trusted as well. But then when we pushed hard against the, to take that consent form out, because really there was no, because after all the data that, you guys are aware of, Viva has worked really hard with Medtronic and with other companies. Viva Society and Dr. Szymski has presented a nice meta-analysis looking at all this data, all this patient, and there's really no direct correlation between Paclitaxel, DCBs, and mortality. And I think the faulty data that we had initially just put everybody in frenzy and panic. And so for us, we really did not change our practice. We know from years and years of putting stents, try to avoid it. Stent-free leg, that's what we're aiming for. And I want to build on a comment on what Peter has talking about. When we're doing a lot of radial to peripheral right now, and the challenge with radial to peripheral is the limited options we have. I think when you have a patient with an EVAR or a patient able to bifem, you can go up and over. Either you can go pedal or you can go radial. What we do is we have a protocol that we built, and over the last years have been very heavy radial to peripheral practice, where if the patient is young and the SFA and poplite have never been treated before, those patient has to go pedal or contralateral femoral, because it's not fair for the patient to first intervention to receive a stent, because we know those stent data between comparing stent versus drug-coating balloon. At this point, drug-coating balloon is the choice we like. So for those patients, we go femoral, as you guys mentioned, and you mentioned the increased risk of vascular access complication and bleeding, and the same-day discharge is lower. But we kept those transradial to patients who cannot get common femoral for one reason or the other, if they have severely diseased, or a patient who has failed a previous therapy. a failed DCB, recoil, we know we're going to put a stent, so we go directly. For all of our iliac patients, we go radial. Rail, we go common femoral, and we just try to get the patient home the same day. So we're very excited when Medtronic is jumping on this and trying to get the 200 out in the market, which is the 1/8, 5 French, 6 French, where we can get, you know, the SFA, most of the SFA, most of the popliteal treated, and then just DCB'd. Of course, we're limited on atherectomies. We know how important atherectomy is. We're hoping that the next step, maybe the HOC1 become a 200 as well. And then we need a filter that's like 350. So we still have a long space, you know, route to take. But I think if you get a DCB, when you have the simple mid SFA lesion, you can balloon and DCB and send the patient home. And also with the growing of outpatient labs, we don't have it, but outpatient labs, I think that'll be great. I think we'll make it much easier.
Yeah, for sure. I agree 100% with the sentiments regarding DCBs and the findings from 2019 and the subsequent debunking. I think the FDA will eventually, in the next hopefully year, respond to all the data that's come out since 2019. And hopefully we'll have a formal retraction of the prior statements. It's certainly a, you know, the radius peripheral age is coming. I think there's patients that are better suited for it. There are patients that might not necessarily be great candidates. I think given the distance, if you have a really complex CTO with tons of calcium, those are still the patients that are better suited for femoral access. So I think the role of R2P, I think, is to be determined still. But certainly having 200 centimeter DCB available in our armamentarium is moving towards the right step for that technology. With that, I would love to thank my panelists, Dr. Saifo and Dr. Monti-Leon, for joining me today to discuss the use of IN.PACT 018 DCBs in the peripheral artery disease. And thank you for your attention and participation in this program.